Hello everyone, I am Manali Reshamwala, Assistant Professor from LJ Institute of Physiotherapy. Today I am going to talk about ventricular septal defect. It is a part of congenital heart disease, also a part of syllabus for final year physiotherapy students of Gujarat University, and the subject is physiotherapy in cardiopulmonary conditions. So let's see what is ventricular septal defect. This is perhaps the most common form of congenital heart disorder. There is a defect in interventricular septum. Here in a figure we can see there is a opening or defect between the two ventricles. So because of that, the oxygenated blood from the left ventricle mixes with the deoxygenated blood of the right ventricle. This is due to inadequate or abnormal development of septum in the fetal life. So there are two types, especially according to the defects where it is occurring in the portion of the septum. So the defect occurs in the muscular or membranous portion of the septum. The defect may occur independently or be associated with other lesions also, like involvement of any valvular heart disease. So here in a figure we can see membranous type, which is occurring superiorly or higher in the interventricular septum, and another is a muscular type, which are shown here in the lower area where the muscular area of the septum is there, and here is a membranous. So these two types are very important to understand. Let's understand the hemodynamics of VSD. Initially, there is left to right shunt, as we have discussed that deoxygenated blood gets blood from the oxygenator, that is from left ventricle to the right ventricle. There is a shift of blood. This is due to pressure variation in the left and right side of the heart. So this is a type of acyanotic congenital heart disease also. If there is a smaller VSD or smaller opening, usually it heals or closes by itself by 4 to 5 years of the age of a child. But if there is a larger one, then it may create issues. It may shows many symptoms like growth retardation and all. And in such cases, what happens that day by day left ventricle pours blood into right ventricle during each systole. So right ventricle gets overloaded with the blood, which is given to the pulmonary trunk. Gradually pulmonary hypertension increases. Because of pulmonary hypertension, there will be exertional dyspnea and other symptoms, as well as pulmonary hypertension increases at sometimes at certain level that right ventricle and left ventricle both have similar pressure, and there will be no shifting of the blood for some of the time. After that, the right ventricular pressure rises even more than the left ventricle, and the shunt reversal may occur. That is, shunt may like blood may pass from right to left ventricle, which means that deoxygenated blood now is getting into oxygenated blood, which will give symptoms like cyanosis. So the size of the shunt depends upon the size of the defect and the ratio between the resistance to the flow into aorta and pulmonary artery. In small defects, the pulmonary flow may be only 1.5 into systemic flow. In larger defects, the ratio increases until eventually pulmonary hypertension develops and the flow across the defect begins to fall, as we discussed. In extreme pulmonary hypertension, the flow will reverse as the right ventricle pressure is now greater than that of the left ventricle. So there will be right to left shunt. Both the ventricles are subjected to a volume overload at that time. So here in a figure we can see reversal of the shunt because of, we can here see the pulmonary artery thickness of the wall of thickness. Because of hypertension, there is a thickness, as well as dilated pulmonary artery. Higher pressure may cause reversal of the shunting, that is from right to left side. So here we can see deoxygenated blood is getting mixed into oxygenated blood. If we see the symptoms, if the patient with having small defect, there may be asymptomatic completely. We have to wait for 4 to 5 years. Even we should not give treatment. We have to just wait for closure, and we have to manage with conservative management only. and the large defects may cause exertional dyspnea and right ventricular failure with systemic venous congestion. So because of that systemic venous congestion, patient may have raised jugular venous pressure, patient will have edema in the lower limb or uh, palm, etc., as well as portal venous hypertension. Treatment includes relief may be temporary in the infant or complete after the age of 3 to 4 years. As we have already discussed, in a small VSD, we are not going to give any kind of surgical treatment. We will be waiting for closure with the conservative medical management, which may include treatment for prophylactic antibiotics to prevent infective endocarditis, or any left ventricular failure or right ventricular failure develops, then the treatment like oxygen therapy, digoxin, diuretics, fluid restriction, etc. should be performed. By that way, we have to wait till infant gets 3 to 4 years of age, and after that we will plan for surgery. For that also we can plan a temporary operation which will give relief if obtained by pulmonary artery bending. So in a case of large VSD, or even sometimes there is a no septum at all, at that time we can give relief some with temporary relief in a infant with pulmonary artery bending. For that we need to take incision is either median sternotomy or left thoracotomy through fourth intercostal space. It is a closed procedure. The pulmonary artery is identified and its lumen restricted by Teflon band. If the ductus arteriosus is present, it is also ligated so that lungs does not get overloaded. So here we can see in a figure there is a arch of aorta, a red one, and the blue one is the pulmonary trunk, and there is a Teflon band by which there is a pulmonary artery bending. What happens with this, that if there is a pulmonary artery bending, it will create some of the backward pressure initially only, just like a pulmonary hypertension. Without producing symptoms, we are trying to get back of the pressure to the right ventricle. So there will be equal pressure in the right and left ventricle, and there will be reduction in amount of shunting blood. Next is relief of the defect, repair of the defect. So if the child is of 3 to 4 year of age, then we can plan a surgery in which we can repair the defect. So for that also we'd like to take incision of median sternotomy. It is an open procedure, that is open heart surgery. The heart is entered through the right ventricle or right atrium. If the defect is small, it can be repaired by primary suture, and if there is a large defect, it can be repaired by a Dacron patch. So here in a figure we can see there is the area or opening or defect of the VSD is being closed by a help of a Dacron patch, so that the shunting has stopped. So these kind of patient requires pre and post operative physiotherapy, which is same as that of the bypass scheme, that is of CABG. We have already discussed in previous video tutorials about the pre and post operative physiotherapy assessment and management in detail for any cardiac surgery patient, just like coronary artery bypass grafting. So please do watch that video for detailed assessment and management by a physiotherapist. These kind of patient after surgery are discharged between 11 to 21st days. For those days, patient is being given in hospital physiotherapy treatment. After that, he is advised to join for outpatient rehabilitation for further physiotherapy treatment. So here are the references. Thank you.